Hi, my name is Dr. David, neurosurgeon specialized in pain management. Today's topic is calcific tendinitis. Calcific tendinitis of the shoulder is a condition which calcium deposits form within the tendons of the shoulder. This can cause pain and limited range of motion. In most cases, it can improve naturally over time, but in some cases, it may require treatment. The most common non-surgical treatment options include injecting a corticosteroid into the affected area, ultrasound aspiration, and extracorporeal shockwave therapy. This treatment can help to reduce pain and inflammation and improve range of motion. In rare cases, surgery may be needed to remove the calcium deposit. It usually occurs in middle-aged adults with a peak incidence between the age of 30 to 50. Symptoms such as pain may occur in 50% of people with calcific tendinitis. The condition is more common in women than men and is seen more frequently in sedentary workers and homemakers. It most commonly affects the supraspinatus tendon, followed by the infraspinatus, subscapularis, and teres minor muscle. It is believed that tenocytes undergo metaplastic transformation into chondrocytes, forming calcification. It is divided into three stages: post-calcification, calcific stage, and pre-calcific stage, calcific stage, and post-calcific stage. The pre-calcific stage is characterized by the absence of symptoms and is the time when fibrocatalysis metaplasia occurs, causing changes in the metabolic state and mechanical condition of tendon. The calcific stage is further divided into the formation phase, resting phase, and resolve phase. After these stages, the calcific deposit will naturally disappear, but in some cases, the absorption of deposit may not resolve and cause chronic pain. The last phase of calcific stage, which is called resolve stage, can cause acute pain due to inflammation. At this stage, the deposit can be seen entirely on ultrasound, and it can be aspirated with a needle in a form of powder that has dissolved in water. Calcific deposits smaller than 1 centimeter may not cause obvious symptoms, but it is known that deposit that occurs in the supraspinatus tendon can cause pain. The symptoms of calcific tendinitis include sudden and severe pain. Many patients present with severe pain that makes physical examination difficult. On the other hand, mild to moderate shoulder pain can also appear intermittently or chronically to these patients. The location, size, and stage of calcific deposit can affect the pain and range of joint motion in a passive movement test. Specifically, pain during passive arm elevation is common. Factors that suggest the presence of symptomatic deposit include the size, shape, location, and degree of inflammation of the deposit, as well as external factors such as obesity and age. Pain is more likely to occur with deposits larger than 1 centimeter and fragment calcification on imaging or in ultrasound, which presents a power Doppler signal. On X-ray image, calcific tendinitis appears as homogeneous and amorphous in density with smooth or ill-defined margin in the subarachnoid space. Although some researchers have classified the deposits based on shape and size, X-ray is now primarily used as a screening test due to the advance of ultrasound. Calcific tendinitis is classified into 3 types based on the amount of calcific deposit on ultrasound. Type 1 is characterized by significant amount of calcium deposit, which appears hyperaqueic and clearly defined on ultrasound. Type 2 is characterized by deposit that appears hyperechoic but less distinct as the deposit decreases. Type 3 is characterized by deposit that appears similar in echogenicity to the surrounding tendons and is not clearly defined on ultrasound. Type 1 is considered to be the formative phase, while Type 2 and Type 3 are considered to be in the resolvative phase. The main treatment for calcific tendinitis is non-surgical. Non-steroidal anti-inflammatory drugs, ice packs, and heat packs are commonly used. Subarachnoidal steroid injection is often used as subarachnoidal bursa is a common passage for release of calcific deposit and is also a site where inflammation is likely to occur. Injecting steroids in this area can often reduce pain. The usual method is to mix lidocaine and triamcinolone and inject it into subarachnoidal space under ultrasound guidance. Extracorporeal shockwave therapy, which is called ESWT, is a treatment for calcific tendinitis. The mechanism of ESWT is controversial, but it is generally explained by direct mechanical effects and molecular biological effects that form new blood vessels. Direct mechanical effects are the effects of breaking down the calcified tissues due to the pressure of ESWT. Molecular biological effects are the effects of forming new blood vessels and promoting the infiltration of white blood cells to devour the calcified tissue. Generally, it starts after the pain relief through steroid injection. Well, this is the end of today's video, and if you have questions about calcific tendinitis, please leave comments below and I will do my best to answer the question. Thank you very much for listening.